Excellent. So good evening, everyone, and welcome to the Design for Aging Knowledge Community, part of the Boston Society of Architects. My name is Philippe Saad. I'm one of the co-chairs of this committee, and I'm joined by Jonathan Lashley, who is the other co-chair of the committee. And today we have a joint session between the Design for Aging and the Healthcare Knowledge Communities, and Andrew Brombach and Cindy Lee represent the Healthcare Committee. Do you guys want to say anything before we get started with the program?
Yeah, sure. So I'm Andrew Brombach from Smith Group. So I was really happy that Philippe reached out and asked us to co-host this session. They take all the credit for organizing it, but we're glad to join in and send out to all of the folks on this call that are associated with our group. So I'm excited to hear this session. So thank you. I don't know if Cindy, if you want to say anything.
Sure. Hi, I'm Cindy Lee from Canon Design, and also excited to be part of this session. And I want to also mention Sarah Markovitz, who was a previous past healthcare facilities chair, who's also on the call. So I'm glad to see that we have a presence here. And Sarah, if you want to say anything too, feel free. No? Okay. So I'll be stepping down next year with a 3-year term limit. And I think Braden will be taking my place if she is on at all. But
Excellent. It's always good to collaborate and bring ideas together, especially across fields. And when senior living and healthcare design come together, great things happen, as we will find out this afternoon in this session. So I just few housekeeping elements. So the Design for Aging meets every other month on the 3rd Tuesday of every month. If you are not part of our mailing list, we welcome anyone who would like to join our mailing list and attend our sessions. This session is a accredited session with the AIA, and I'm going to drop into this chat, for those of you who most recently joined us, the form where you could put in your credential and receive 1.5 HSW credit for this session. It is recorded and it will be on our website. Give the BSA maybe a day or two to edit it and put it up on the website. And there's going to be other supporting materials and references that our speaker, Addie, will also share with you, and all that will be on our webpage. With this, I would introduce our guest speaker, Addie Abushousheh. Addie Abushousheh is a gerontologist, researcher, and consultant for organizational and environmental development in long-term care. She explores cultural and biopsychosocial perspective, that's what I love, organization structure and processes, physical environments, workforce models, and regulatory financial framework in relation to decision-making, resource management, and quality improvement. With combined expertise in architecture, organizational development, aging, and applied research, Dr. Abushousheh advances comprehensive and translational agendas related to quality assessment and performance improvement. Addie is a research associate with the Center of Health Design, an adjunct member of Kent State University, and a senior living advisor for Abacus Institute. Now that is the formal introduction of Addie, but I would like to add my personal note to this. Addie and I met fairly recently, but as we say it to one another, it's one of those fastest growing friendships. There's a lot of aha moments when we meet and we get together, and we, if I may say, Addie, we kind of see the world maybe in a similar lens, almost kind of in the same direction, and we know what the other one's going to say before we even say it. I met Addie through the publication and platform Environments for Aging, and they put me in contact with Addie. Addie asked me to do an inclusive design presentation for the Center of Health, and now Addie is very gladly returning the favor. We also serve on the Facilities Guidelines Institute revisions committee for the upcoming edition that will come up in 2026. So we've had a lot of very meaningful discussions and I would say discoveries about how we can really push the FGI guidelines forward into the next decade. With this, I am thrilled that Addie is here to present to us today about her work and the Center of Health, and actually also another very important aspect of what the Center of Health does and Addie supports is the evidence-based design EDAC certification that she will be talking to us about today. With this, Addie, take it up.
All right, I'm going to go ahead and share my screen. Thank you, Philippe, for that introduction. And let me know if you're able to see screen. Okay, very good. All right, so basically that very long introduction means that the only thing that I really have retained from my professional degree in architecture is my poor spelling, because I have a 24-letter alphabet. It excludes N and O. So the more I learned I didn't know, and the more that I wanted to advance the health and well-being of a population that typically doesn't have an opportunity to advocate for itself. As a part of that, I really grabbed onto this notion of evidence-based design. And that's something that I want to share with you today because it has special application and meaning to healthcare environments. And despite the fact that my expertise is aging, we are actually caring for 94% of the aging population in acute and ambulatory primary care, other settings than long-term care. So most of them will not see the insides of the walls of long-term care. All of us, however, will grow into a point where we benefit or we're subject to design strategies that fail to or that do enable us. So today, on behalf of the Center for Health Design, it's my absolute pleasure to talk with you about maximizing health through informed design using an evidence-based design approach. You know, I think it was Winston Churchill who said it best: we shape our buildings and thereafter they shape us. And in fact, the physical environments are one of the most obvious and enduring reflections of our collective values and priorities, and they continually influence the behaviors of every single one of us who encounters them. It's especially important to consider healthcare settings because while the provision of healthcare might be a medical issue, ensuring access to healthcare environments is a design issue. I'm going to do 4 basic things today. I'm going to talk a little bit about the evolution and application just to orient you to evidence-based design, help you understand how evidence-based design can be used as a process, introduce you to a EDAC certification program that increases recognition and reach within the industry. And then ultimately, what I really want to get to is helping you recognize how evidence-based design could be used to move the needle of consciousness in the projects by advancing person-centered care. All of the touch points within my volunteers, committees, work really do serve to just give me this remarkable opportunity to stay informed and up to date on what's happening nationally as well as internationally, and then bring them to bear within my sphere of influence. And I'd like to invite you to join me in that regard. The Center for Health Design is a 501c3 organization dedicated to maximizing health through informed design. We advocate for multidisciplinary approaches and broad stakeholder engagement, and we're a trusted resource, but we cultivate mutually beneficial relationships that allow us to learn from each other and support each other as we move forward as an industry. So I'm going to kick off by talking about the origins of evidence-based design for anyone who isn't familiar with this. The roots of evidence-based design can be traced all the way back to the 6th century BC, when building design and layout began to demonstrate an intention to create healing environments. The Asclepian Hospital in Greece had rooms that faced east to promote healing, and it was celebrated as a healing center. That decision was made pretty intuitively. However, a more evidence-based approach dates back to the 1860s when Florence Nightingale identified fresh air as one of the very first canons of nursing and emphasized the importance of quiet environments proper lighting, warmth, and clean water. Evidence-based design, for short EBD, is similar to the path that evidence-based medicine followed in the early 70s. Archie Cochran's book, Effectiveness and Efficacy, Random Reflections on Health Services, established research methodologies for us to collect, codify, and disseminate evidence gathered in randomized controlled trials relative to the built environment. There have been a lot of forces, however, that have come together to converge to create the field of evidence-based design, and this timeline depicts some of those key events. Much of that evidence was built up over the last 50 years by researchers working in the fields of environmental psychology and related multidisciplinary fields such as environment behavior that included architects, interior designers, sociologists, anthropologists, and others. You can see here where the field of design began to take a concerted effort to understand the intersection of person and environment, roughly the same time as the codification of research methodologies underlying that evidence-based medicine approach. 10 years later, evidence-based design found a really strong foothold primarily within hospital and outpatient healthcare settings, and that was largely owed to the seminal study by Roger Ulrich. He was a behavioral scientist. In 1984, based on stress reduction theory, recovery records were retrospectively reviewed for 46 patients that were assigned to rooms that were similar in character. The difference was each one of them had a different view through the window. Half got a view to landscape versus the other half that had a view to a brick wall. Patients with views to nature recovered on average 1 day sooner. The coding of nurses' notes revealed more positive recovery experiences, and there were fewer moderate and strong medication doses on days 2 through 5. Now, these were statistically significant. For anybody who doesn't speak research, what this means is there is a 0.01% chance that these changes could be credited to something other than looking to nature or the brick wall. After extensive engagement with thought leaders designing and constructing healthcare environments like Roger, the Center for Health Design was incorporated in the early 90s. 1 decade later, one of the center's board members is credited with the first attempt to formalize the definition of the term evidence-based design. In 2005, Kirk Hamilton sat on our board of directors and requested that we help to formalize evidence-based design. He wanted the center to begin to provide education. CHD received a grant from the Robert Wood Johnson Foundation, and working with Kirk and Roger and other volunteer experts, including me, we created the EDAC program, which was formally launched in 2009. Here is the definition of evidence-based design, but what I'd like to point out is that it's really a process, because basing decisions on credible research is an ever-evolving proposition as environmental design strategies, tools, and evidence changes, and various outcomes assume different priority by care providers, the industry, and of course, regulators. The diagram here illustrates how 8 phases of evidence-based design are typically or are laid out to follow the typical process associated with planning, design, and construction. While the process appears linear, similar to the design and construction process, it's not necessarily, and so there can be a lot of back and forth as necessary. We start with defining evidence-based goals and objectives that serve as guideposts during the pre-programming process. Then sources for relevant evidence are sought to explore the potential of the built environment, internal, external, community, and beyond to advance those goals. The team then critically interprets the evidence that they've found for relevance to a project. Innovative and prioritized outcomes are framed as evidence-based design concepts in DDs, CDs, and specs. And then hypothesis statements and associated metrics are articulated that guide post-occupancy evaluation. Baseline performance measures should be collected if possible or gleaned as the basis for future evaluation. Implementation is monitored to safeguard those design features during the design, VE, and construction process that we're relying upon for outcomes. And then finally, the team monitors performance during initial occupancy and then measures the results after an appropriate organizational settling period. Built on the experience and foundation of the EBD process, the center created a detailed evaluation matrix for submissions for our Touchstone Award. They're based upon the success in achieving criteria in 3 categories: collaboration, evaluation, and sharing. The Touchstone Award recognizes the use of an evidence-based design process in the pursuit of increasing value, improving outcomes, and engaging stakeholders. Awards are given to projects that demonstrate exemplary achievement of the 3 touchstones in the EBD process. Here you can see some of our Touchstone documentation that's available for download on the center's website. I mentioned to Philippe when we got started, I have constructed 2 spreadsheets because I am a spreadsheet queen. And anyone who's interested in receiving these, I'll share my email at the end. You're more than welcome to reach out to me. I didn't want you to have to accept these if you didn't want them, but this provides the intersection between the criteria where information is judged and what we typically look for within each one of those phases. And then it's further broken down into detailed content here. But why healthcare? Why design? Why research? Why this intersection and all? So design, research, and health and care all intersect in various ways and result in a variety of products and services. Typically, what we'd like to think of what we do is evidence-based design. The degree of evidence varies, however. When we think about the intersection of research and healthcare, however, we want to be sure that there is absolutely credible and reliable research that we are having decisions based about our healthcare based upon. And then we get to design and healthcare. And this is typically where most of us in the design profession reside. Maybe there's some evidence, but most of it's just health design. What I'm proposing as a part of this presentation is that we get to the point where we can have that evidence-based health and care design and be able to capitalize and rely upon that reliably. It's especially important for us to use this EBD process in healthcare because of the very personal and complex services that are provided in places that are filled with fear and wonder of life and death decisions. These buildings are the most obvious and enduring symbols of our priorities. And while the provision of healthcare, again, is a medical issue, ensuring access to that healthcare service is an environmental one. For designers, it's important to understand that the design can help support improved outcomes and address the challenges that are plaguing our industry. This certainty becomes undeniable when the COVID pandemic, especially for people living in long-term care environments, started to rage within the long-term care and acute industries. EBD can help to develop solutions to create those sustainable outcomes. It is one of our personal objectives within our profession to advance the health, safety, and welfare of the individuals we design on behalf of. As such, we are healthcare professionals. We are the first healthcare provider as the designer of environments, and we should be held to the same level of accountability as those who provide direct healthcare services. First and foremost, do no harm, and that relies upon leaning on the evidence that we have available to us. I want to shift gears here quickly to talk about aging and dementia, because this is something that is going to increasingly have relevance no matter what kind of healthcare environment we're designing within. Like I mentioned earlier, 94% of our aging population is receiving services in healthcare environments other than long-term care, and they are disproportionately negatively affected. So this is the point at which we really want to pay attention to this. More than half of our hospital stays for people of age 65 and older are associated with Alzheimer's disease, with inpatient stays being 4 times more or longer. People with dementia are more than 2 times as likely to have ER visits. 4 times as frequently in comparison with others. They're admitted upon those visits. They're more than 15% more likely to receive services than other older adults with home health care. And we really should be leaning upon other designers who have gerontological specific expertise in that regard. EBD helps to bridge that language divide because we do have different languages that we speak within the 2 professions. In my opinion, really the place to start is by understanding the most fundamental needs of the people that we're working to design for, and this is part of that evidence-based knowledge. Our abilities change as we age. First and foremost, we've got some changes that are typically associated with aging, and then we have some that are not so common. Those that we can rely upon are changes in our bones and joints, our muscle mass, digestion and metabolism, bowel and bladder, teeth and gums, our skin, balance, coordination, and reflexes. Also our vision and hearing. Each has an implication for the design of the built environment when considered in isolation, and all of them have major implications when we consider them collectively. It used to be that memory loss was considered a normal part of aging. However, what we've discovered is that recollection certainly can be delayed, but significant memory loss puts us into a different category. The changes that can be credited to Alzheimer's disease and other related dementias are noticeably different than those that are typical of normal aging. We understand that dementia is an umbrella term for many diseases that can affect memory or other cognitive abilities and behavior that interferes significantly with a person's ability to maintain their activities of daily living. So when we think about Alzheimer's and other dementias, we're thinking memory loss to an extreme, judgment and recall, confusion with time and place, misinterpreting imagery and spatial relationships, challenges planning, problem solving, completing tasks, difficulties with language, social withdrawal, and changes in mood and personality. So this is something to consider across all of those healthcare environments. In the context of caring for individuals living with the symptoms of dementia, I want to revisit this EBD timeline to put the pioneering work of M. Powell Lawton into context. Here's where one of the best examples of the first specialized nursing home setting for people with dementia was developed in the 1970s. The Philadelphia Geriatric Center. Under his direction, the Weiss Pavilion represented a radical departure from the traditional nursing home in that it was designed for only 40 residents in single and double occupancy rooms instead of the more typical 60 patients in 4 to 6 person rooms. The bedrooms were arranged around a large open space that contained living, dining, and activity areas. The intent was to compensate where possible for disorientation, memory loss, loss of social skills, and sense of self. The challenge with this was there were so many variables changed all at one time. It was very difficult, unlike Roger Ulrich's, to credit the changes to one single design variable. To date, in the absence of a prevention or cure for most types of dementia, the most effective treatment that we have consists of the objectives listed on the left side of the screen. Lawton's ecological model for aging highlights the way in which we can use varying degrees of environmental complexity to advance these common therapeutic objectives for aging and dementia. And this model highlights the way that we can either enable, enfeeble, or disable individuals. I like to use the example, you're not going to put me on a bunny hill because I'm going to be incredibly bored with that, but you're not going to put me on a black diamond either because I'm going to be broken by the time I get to the bottom. As we consider these objectives, we're not a one and done kind of proposition. We really do have to consider these at all levels of scale as well as location. And that's the same with every single application of evidence-based design. We are thinking at all levels of scale and location. When we think about aging and dementia, we really are trying to promote these outcomes. It is equally important to think from an evidence-based design perspective that we are not doing this in a vacuum, especially as designers. No matter how precisely and skillfully we execute design strategies supported by research-based evidence, the built environment is only one integrated aspect of a complex adaptive system. Weissman's model of place contends that we have to consider all of these influences of incorporating ideals, organizational directives, the environmental context, and the intersecting operational space where individuals play out the actual provision of care. So in the meantime, while we're thinking about all of this, let's take a closer look at that evidence-based design process, beginning with this first phase that starts with defining evidence-based goals and objectives that serve as those guideposts during the pre-programming process. In the context of long-term care, the field of environmental gerontology, we have a rich history that represents both gradual and radical shifts within the provision of long-term care. I'm going to situate the lessons that we learned from the Weiss Pavilion right here, because one of the things that has changed the care provision in long-term care more than anything else is highlighted here in yellow. The Omnibus Reconciliation Act of 1987. This is where, in addition to the quality of care, we placed equal priority on the quality of living of the environment, which had pretty major implications for the way that we were both delivering services as well as constructing environments. So when we think about those underlying goals for evidence-based design, we really want to be clear about what an organization's intent is in that regard. When we think about the provision of person-centered care, it was a dramatic cultural shift within long-term care. And for a while, it was called culture change. What we generally refer to it as patient-centered in acute and outpatient settings, person-centered in long-term care. It was perceived of as the right thing to do for a long time, but gradually we began to accumulate an evidence base. The comprehensive delivery of person-centered care is dependent upon the widespread and cohesive infusion of a set of principles that you can see here. And all of these do have major implications for the built environment and vice versa. In long-term care, I participated in a pre-dissertation research project that attempted to codify some of the principles underlying the design of the built environment so we could build the evidence base. And we convened a meeting, first a survey of about 400 people around the United States verified to be participating in advancing person-centered care, and then had a smaller group meeting with regulators, architects, providers, designers. Typically what we saw was that groups of people that ranged from 10 to 20 tended to experience the most positive outcomes when they were consistently socializing with one another and familiar with one another. And settings that held these types of groups were more beneficial than large settings. The building really needed to be intimately sized and have some clear boundaries so you knew when you were in and when you were out. The more we could capitalize upon familiar residential hallmarks, the better. And the more we could hide the institutional hallmarks, the better. And then we're typically different in terms of our operations. This is where the consistency of staffing that was realized as a positive approach during COVID came out as a result of the work that this group did. And that was 13 years preceding. And then the organization has a significant restructuring. So this is also something that as you are thinking through that goal base, understanding how the organization operates is going to be absolutely critical. In person-centered care, we have distributed accountability for decision-making versus that hierarchy that we would typically see in institutional propositions. After we are certain that we know what our goals are and the kinds of organizational approaches that we're basing our decisions on, that's the point at which we want to find relevant evidence. Here, we're going to try to explore the potential of the built environment, again, internally, externally, community, and beyond, to advance our goals. And when it comes to looking for aging, relevant sources for information, it isn't necessarily a straightforward proposition. Identifying design strategies to accommodate the needs of individuals experiencing physical and cognitive frailty occurs across a variety of settings and frequently in nonlinear fashions, from a person's home to long-term care to the hospital. And there is a lot of information out there. So where should we begin a search? You should expect to find that there is not only a lot of information out there, but a lot of it can be misleading and contradictory. It can be really challenging to figure out just how and where to start, and even more challenging to try to sort through all of that to determine what's relevant. So here's the way that we can start to think about what information we really ought to be looking for. We need to figure out how to ask the right questions and determining what is it that's actually of interest. If we know the goals of the organization, those should be the drivers. And goals of the organization can either be aspirational or they can be reactive. If challenges are being met, if you've got failures within the system, those are gold mines for finding goals. This ultimately goes toward what I would say is defining the research question. That's going to help you perform your search and be systematic in a way that you wouldn't otherwise. And the way that I look at this is you've got a whole lot out there that you want to search. It's the way that you choose to search. I'm going to introduce you to a new term here called Boolean searching. And this is a combination of words that you can use. And there are a lot of different search engines that enable you to use this type of search strategy. So you can search for multiple words in conjunction with one another. You can search for either this or that, or you can search for this in the absence of that. And this becomes really helpful whenever we start to think about isolating search hits down to, say, a specific healthcare environment. Here's some possibilities for you to begin to execute, trying to find sources for your evidence-based design. I think that your first and best strategy is going to be to hit that CHD knowledge repository within the Center for Health Design, because we have searches that look through all of these other potential options and filter the hits down to the research team. All of us have a environmental research expertise and get to determine if there is something that has direct implications and application for the design community. So that's something that's a good resource for you guys. Online journals, those are fantastic if you have access, but a lot of those are behind paywalls, and you might not necessarily have full access to that without paying sometimes upwards of $80, $90, more than $100 for an article. If nothing else, come back to the Center for Health Design's knowledge repository, see if there is an abstract that's available, or if we've got a key point summary such that you really want that article. Abstract and indexing services, again, that can be behind paywalls. A lot of those are now, as a result of COVID, available to you. Just make sure that you're very specific about your search terms, and then you can go to the more common search engines that are available to the general public. If you're going to search Google, please type in Google Scholar and use that feature to search for any evidence that you're looking for, because you're going to get less material that's based upon manufacturers' evaluation of their own products. And then you've got organizations and societies as well that can help. So I'm going to give you just a quick run through of the center's website such that when you get there, you're at least familiar with it. If you go up here to research and then down here to knowledge repository, that's the way that you are going to access more than 8,000 research article abstracts and citations. When you get in here, that's the point at which you can either go ahead and start your search. I like to go with these how-to videos as just a place to start. Here's the link for you, and that's on a PDF that will be supplied to you as well. And it'll give you 3 general videos. They're super quick to watch, and it can just give you an orientation of the way in which you can maximize your use of the center's repository. Once you get in there, you're going to find, again, a ton of citations and some key point summaries. Here is a 2-page key point summary that I did some time back. This is going to give you your basic translated information for from research to design application. Here's the article that was underlying this 2-page summary. And reading these, just quite frankly, is painful for anyone who's not in research. A lot of times, what we try to do is take the reading out of it altogether, and we will present a 5-minute video that summarizes what you would want to know about that research article and its application for design as well. So next we get to critically interpreting the relevant evidence that we found, or the relevance of the evidence that we found. Credibility is huge. We want to know that a manufacturer isn't just advancing their own product. So we've got a variety of ways that we look through this that I'm going to help you understand. So on this scale toward the left is subjectivity. These tend to be isolated studies that are in a specific environment. They may not be as generalizable to other projects as the kinds of studies that you would find on the right side of the screen. Whenever we're looking at trials, clinical trials especially, you have massive numbers of individuals who were involved in these so we can assure that generalizability across a population is going to be reliable. Internally, what we look for is what time frame was something conducted within. Is the time frame relevant to us? What were the key concepts or the context in which it was performed? What methods were they using to try to get at their study? What did they find from it? And always, always the limitations. If you find an article that either claims it has no limitations or doesn't cover it at all, you should suspect that article absolutely as being something that's pretty suspicious. And then the design implications. What are these, in fact? What really matters? Next, as you have found some information that you think might be valuable to you, this is the point at which you want to in turn then create and innovate. This is what I say that, architects, it turns us from magicians into logicians. And we get the credit or the blame. I'd much rather get the credit. So this is the point at which we're justifying what we're doing. If we're providing specific criteria, either in relationship to the performance characteristics or some type of prescriptive measure for the way that something is to be applied, despite the fact that building codes and guidelines stipulate performance and prescription criteria for design. Too frequently, outcomes aren't considered and are an unintentional consequence of our design decisions. Then we go on to develop a hypothesis. I think all of us do this as designers kind of inherently. We imagine that a particular design strategy will produce an outcome. We just don't write it down necessarily. What I'm saying here is we're writing it down and we're predicting a kind of expected application to what we expect to see. So during this 5th phase, the identification and documents linking outcomes to design strategies isn't usually a part of our decision-making process, but it ought to be. And this is the way that we set up what I would call hypothesis Mad Libs. Only in my mind, we work backward. We start with that outcome that we're trying to achieve, decide if we wanted to see more of it or less of it, and then look at the design intervention that we think is going to affect it in that regard. It's all about just linking things together. If we have challenges, again, those are absolute gold mines for goals. Goals in terms of what we want to increase or where we see regulatory reimbursements going, those are also gold mines. And then the design strategies that we can link to that. Once we have those in place and we're working on our CD set, if there's an existing organization where we can start to collect some of that baseline performance measures, that's the next phase of this EBD process. If we don't have an existing organization, that's the point at which we want to look to the literature to try to predict just how much something may or may not change. And so here, this is where we start to leverage the hypothesis statement in order to collect that initial baseline data so we can compare it with the post-occupancy data. And we want to know how we're measuring it and how much our prediction is that it's going to change. From a measurements perspective, there are a lot of different ways, and there are a lot of different ways that are really time consuming. Surveys are a time suck. If you have access to data that is collected within the organization that they find meaningful to themselves, have them share that with you in a capacity that you can access it or summarize it for you in a way that it becomes meaningful to the design so you can measure it again after the design has been completed. Ultimately, what we're trying to get to is developing this business case, because we all know during the VE process, anything that costs more is on the chopping block. So if we have a predicted value in terms of a first cost, let's see if I can get over here, a first cost here, but there's going to be a return on that investment over time, we want to know just how long that anticipated time frame is before they start to realize a profit. If there's a profit or a lack of expense that can be used as a justification for including a design strategy or element, that's where we want to be. And this can be applied at all levels: building systems, construction documents, design, environment. And one of the things that I think we overlook consistently is litigation. We are all litigation averse within the industry, especially healthcare providers. If we are making decisions based upon an evidence base and we are documenting that all the way through, when it comes time and something does happen inevitably, there will be a record of how a decision was made and who signed off on it. Having a multidisciplinary group that includes the care provider is absolutely essential, because it takes that kind of informed decision-making by multidisciplinary groups in order to make this practical and relevant. During the 7th phase of the evidence-based design process, this is the point at which we're doing the design and construction. We're going to be monitoring the implementation to safeguard design features and to make sure that if we do sacrifice a specific design feature, we are substituting with something that has a comparable kind of performance expectation. I'm going to give you an example here of a set of CDs that was shared with me by Robert Rulowski out of Canada with MMP Architects. Now, this is an evidence-based design CD set. And so what he's gone through, and he's created an evidence-based design schedule, similar to what we do for a finish or a door schedule, and annotated the plan as to where specific elements are intended to either benefit from or achieve outcomes. And this is the point at which it opens up a different kind of dialogue, especially when you have construction managers who are looking at this set and need to call back to understand or to get verification for substitutions or alterations in construction. Then we come to the POE performance results. During this 8th phase of the EBD process, the team monitors performance during the initial occupancy and then measures the results after an appropriate organizational settling period. Now, in addition to a professional degree in architecture, I went through organizational development because I recognized that it is this intersection of people interacting with the environment that resulted in either the success or the failure of environments. And organizational settling periods, I've never seen one that is less than 18 months. Basically, what people are doing is returning to a status quo for expected performance within an environment. They start to take things for granted. And at that point, they're not trying to adapt their performance to a new building. This is once again where our measures come in handy. If we've managed to collect pre-occupancy measures or existing measures, that's the point at which we can start to compare them. This feeds in not only to the organizational success and their confidence in you as the designer, but we can carry that forward in other projects and not only rely upon the evidence that's being generated by others, but the evidence that we are generating as well, which actually brings me to this additional envisioned step in the EBD process. When Kirk came up with the evidence-based design process, he envisioned it at 4 different levels. So we've got level 1, where we hit some of these interpretations of evidence and the way that we might apply them. Then we get down to that hypothesis and measurement approach. Here we get to this sharing publicly what we've learned. And this is ultimately where I want to encourage you to think about either public presentation, trade magazines. Come to me within the Center for Health Design. We share resources and results in all kinds of capacity, and we want a learning from doing kind of approach and sharing with others in the profession. And then ultimately, if you have partnered with a research entity, the Center for Health Design could be a university, could be another researcher within the firm. This is the point at which you can meet those academic standards for publication and really contribute to the body of knowledge within the field. This is person-centered care in a nutshell, or a spreadsheet, however you want to look at it. And Philippe, thank you so much for inviting me to talk with you about this. Clearly, I'm passionate about it.
Addie, thank you so much for giving up a good amount of your time to talk with us. And it is not the first time we talk about this, but every time you speak about it, whether to me or in a setting like this, I learn way more and I get more excited and a lot of things come to mind. We can open up for discussion and questions. And I have a few questions, but before I go in, I want to see if anybody has anything for you right now, just as a start. Please feel free to unmute. Yeah, go ahead, John.
Well, Philippe, I'll join as the coach, jump in as the co-chair. I want to say thank you, Addie. That was excellent and really interesting. So thank you. I had a comment to start with, which is that, so I do design for aging and seniors. That's not health focused specifically. So this something you said earlier in the presentation that just really sticks with me, that as architects and designers, we are the first healthcare providers for people who are in our built environments is just a great concept. So thank you for putting that so succinctly. My question for you would be, given all you talked about evidence-based design and research, architecture is a client and developer based profession. My question for you is, how does one convince the client or the greater powers that be of the importance of going outside of what is known and introducing research when perhaps their goal is short answers or quick quick solutions that are already established?
So I'm going to draw upon some of the expertise that I have gleaned from other folks who I have the benefit of their company on a pretty regular basis. And one of the practices that I do as well, I ask a lot of questions, like a ton of questions, just to make sure that I'm understanding. And in those questions, quite frequently, people, they hear themselves answer, whereas in assumptions that they're providing, they can give those, like they'll provide you with the program, they'll provide you with a one sheet, they'll do whatever. But when you ask very specific questions and they have to respond in that moment, and even better if they have to respond in writing, then you have information with which you can start to try to sift through goals. It's the prioritization of those goals ultimately that I use and that I've seen others use as their basis for determining where to put their money. Some others shift some of the money that they would ordinarily put into the addendums, the changes that occur during construction into the programming process, because they were able to achieve a greater degree of clarity and shortcut some of those changes that they would see on the tail end. And so that's really helpful to understand. And then, others, it could be an additional service that's rendered, or it's just a matter of looking in different places for the information instead of going to vendors and manufacturers' sites, like as a first stop. I really think that the knowledge repository is, I hear it repeatedly, it's the first stop for just getting a litmus test on things. But ultimately, asking the client to tell you the goals based upon where are you experiencing challenges, where would you like to head, and then assigning a priority to those.
And that's and that's the opportunity right there.
Yeah, because if I've got something that's fifth on the list, I'm going to give it far less focus unless it's achieved by virtue of achieving the first thing on the list.
Addie, there's a question. Go ahead.
I just wanted to make sure, John,
Yes.
that I got to your question completely.
You did. It's something to think about, because I think this is very exciting, and I'm just knowing that you have to temper it with expectations on the development end. But
they're measuring their successes either through reimbursements, penalties, length of stay, recidivism, you name it. Whatever their metrics are and they're experiencing their priorities, steer into that skid.
yeah. Great. Well, thank you.
Can I add one thing to this also before we go into a question in the chat, Addie? But adding this to John, the rigorous process that the Center of Health has outlined for it is a phenomenal map for achieving evidence-based design. But sometimes the whole thing is not applicable to every client, and there is so much there that you could pull out that a lot of us do when we sometimes have a programming session and we ask questions. This is part of that, but we most times don't do the whole process as it's outlined. That would be valid or a criteria for to call it evidence-based design and then to receive any awards that the Center of Health has dedicated for that.
Well, and I notice a lot of clients trying already, like whenever you enter into a new construction, renovation, addition kind of conversation with them, they'll already be trying to translate for architectural application and asking them to in turn tell you their priorities. Like, we have 10 minutes on average that's wasted getting people from their rooms to therapies. That's not billable time. We need to reduce the time. Just tell me what your goals are. My job is to figure out the environmental acrobatics to make that happen.
Yeah.
And that's a good anecdote. So there we go.
There's a question in the chat that you're gonna like. It's from Tim King. He's asking if there's a correlation with the I of the DEI inclusion efforts or initiatives. Is aged disabled in the range of ways qualified as a group for inclusion when planning and executing healthcare design? Has it been seen in this way after years of EBD growth?
Okay, that is an awesome question. And
I
yes, I
know.
do love that question. So yes, I would consider, and increasingly legally, it is considered that from an accessibility perspective, aging and dementia, because it is physical and cognitive frailty, is under that umbrella of inclusion. And ultimately, what we're trying to get to within the evidence-based design process is making an environment accessible to the greatest degree of individuals possible without imposing additional disability. Disability arises when an environment or an attitude fails to support a person's impairment. And that extends, like the ADA only covers certain types of impairments. There are a whole range of impairments. Neurodiversity, we think about English as a first language, marginalized population, healthcare skepticism. All of this needs to be considered as we're thinking about the application of a healthcare environment within a specific setting. And this is where I think that it's important not only to open up conversations with the healthcare provider, but also think about the community and perhaps getting into some GIS analysis for citing healthcare locations of what the market sector might look like and who they really are serving, and bringing them to the table as well.
Tim, are you're good? I noticed you've unmuted yourself. Anything you would like to add?
No, I appreciate it. I say that because recently the Mass Hospital Association had an event and one of the panels was on DEI, and one of the panelists was from the state Department of Public Health, and she was the DEI sort of representative, and she herself was handicapped and identified in a couple of different ways, not common to the people in the room. And so I just wanted to say I see the correlation directly, and I wanted to know if they were running separately, concurrently, side by side, melding in the middle, how that was going. Maybe each other can give each other legs and a boost.
So yeah, it's interesting. I'm working on this. It's basically a design lexicon, which is like a design dictionary for aging and dementia, where I'm looking at design inputs, direct outcomes that are organizational, related to the care provider, specific to individuals receiving care. But then we have other considerations, and DEI is definitely within that other consideration kind of category. It's not singularly an outcome because it can also be a design input, and vice versa. We might consider other building related outcomes that are aligned with decarbonization, LEED, things like that, to be one of those other considerations. They are highly relevant and should be a part of the conversation that are informing the selection of materials, the sourcing, all of that. Something that I thought has been particularly interesting in the work that I've done recently within a hospital system on the East Coast has been, we were looking at the misdiagnosis of cardiovascular disease in women and looking at the environmental kinds of propositions put forth there. When we did GIS analysis and we were looking at the siting of hospitals in relationship to individuals who are being misdiagnosed, especially when it relates to minority and low-income populations, that was very telling. And so I would encourage everybody to think not only within the building envelope and on the site, but also siting. Care provision is another thing. And I don't just mean like who the care provider is that's providing care to older adults. We have an aging workforce. and trying to avoid errors there is going to be aided by lighting, certainly distances, ergonomics, excess or regulating stimulation within the environment.
Thanks, Addie. If you have a question, you have a comment, please feel free to put it in the chat or unmute.
There's another presentation that's coming up on Thursday with the Center for Health Design where Granger has asked me to present, and I'm going to be presenting a lot of material on some philosophical shifts within the healthcare industry and the way that it relates to the environmental propositions that are being put forth. So be more than welcome to tune into that. It's an open access presentation.
Yeah, a lot of the things that the Center of Health provides, whether it's webinar or resources, is open to everybody. Eddie, I have a question about the process, and then I would like you maybe to talk a little bit about the EDAC certification, maybe
Yeah.
in a quick nutshell, if you don't mind. But my question is, when is there an involvement of the Center of Health in the process of implementing the evidence-based design? For those who are maybe starting or not doing it on a daily basis, does the Center of Health provides consultation besides this beautiful, very detailed spreadsheets and the resource material? Is there like a hand-holding possibility?
You're kind of like the one-stop shop for EDAC. Yeah. So in terms of advancing evidence-based design, everything that we do is underlaid by an evidence base. So any of the resources that are produced, that are a resource available. However, if you go into the EDAC tab, you are going to find amazing resources that are books and flashcards, study material, all sorts of things related to that, but then all of our member presentations, study groups, small group conversations, large group presentations. Any one of those can be used by someone who has varying degrees of confidence with their ability to make it through the EDAC exam. In my experience, what I'm seeing more frequently is really designers are doing this anyway. It's becoming accustomed to actually formalizing a process and kind of allocating what we're doing into those phases and developing a language that puts us in a similar kind of lane as healthcare providers, because most of the conversations they're having outside of conversations with us are evidence-based. If we're leaning into them and with that language, then we're going to where they need us to be. Ruth, I see you have a question.
Philippe, and Addie, I just want to build on this question. I was waiting to ask, and Philippe almost stole my my idea, because at one moment you said if you have a joint venture or collaboration with a university or a research institute or the Center for Healthcare Design, then. So I know that especially for us, like small and medium-sized companies, putting a lot of time of senior people and principals into research is almost impossible. And we do not speak the research language like the researchers. So several times we had a situation where we had a great idea to actually follow up and do a more deep or prolonged POE on, for example, a few years ago, using circadian lighting in a memory care unit. And we were able to get a lot of anecdotal information from the people in the unit, but we really wanted to do something that would be eligible for publication. And we kind of were stumped. We didn't know what to do. I think we did apply to somebody at the healthcare Center for Healthcare Design, and kind of it fizzled out. So what do we do to make it work better?
Okay, so here is where science is full of people who can beg, borrow, steal from each other with the expectation that it has to be done. When we publish in a peer-reviewed capacity, we do it with the intention that someone can replicate a study with circadian lighting. That's pretty low-hanging fruit because there are a lot of studies that have been done thus far. That's where, if I were pursuing this as a designer, I'd log on to the center's website. I would find the study on the knowledge repository that I could replicate. I can reuse their methods. I can reuse their kind of approach. So I can too basically see they achieved this outcome. So I'm predicting that you're going to achieve a 23% change in whatever that outcome is. At that point, you don't have to spend all of that time doing a process that is unfamiliar or foreign to you, because you're not expected to be a researcher. However, you can copy a study. That's why we put it out there, is to be copied and to have information that is freely accessible to folks.
Mm-hmm.
One of the suggestions I would share in terms of engaging researchers, if you are a small firm especially, that's the point at which I think it's really beneficial to connect with universities and potentially engage graduate students, because they're always looking for something. In an academic environment, it is a publish or perish proposition. And so, you know, if they have the opportunity to apply something and study it, quite frequently that can be done as a part of a graduate project or a class, or even an associate professor trying to advance to tenure.
Okay,
And they will write the grants.
And that's brilliant, Ruth. That was sort of going back to my question at the beginning too, right? How does one convince a medium-sized firm? How does one convince ownership to make time or money or room for this? So,
well, their dollars,
Right.
what they're experiencing in terms of losses or envisioned revenue should be motivation if you're doing your business case.
Cindy, you had a question. You had your hand raised.
Yeah, so many years ago, I worked on a renovation for Mass Pioneer, and I think it was before like the EDAC group was created, and the clients were asking us to look at the design, the colors, the materials, and make sure it's designed for people with low vision. So, you know, it started this huge looking up publications. There was none. We reached out, we found someone in Israel who had some more knowledge. We actually talked with her, had a visit. She came, visited us, and we put out a survey to some patients for some color combinations and tested it. So it's not a true research, but like, you know, if EDAC existed when I was working on that, I would have looked it up, and I still don't see a lot of stuff on that topic. I was just kind of curious to see. But if there was a problem and you didn't have any information on that, on the Center for Healthcare Design, what would be the process? Would you reach out to the CHD and get connected with potential?
Yeah, we have a lot of folks who will reach out to us to see if we're aware of anything that's been published. And that's where also going to these design journals can be helpful as well, to do a search. And you know what, connecting with the university because of their access behind payer walls is another really great way. So if you've got a local architecture school, I know that they've got access. Seeing if their master's students can assist in locating some information is helpful. Yeah, I don't pretend to have everything, but one of the things that I'm working very diligently at is to try to identify, harvest, and make accessible in a filterable kind of way the design strategies and outcomes that are specific to aging. Sorry for our acute and outpatient counterparts on the one, but if you're into aging specifically, outcomes that tend to support those who have neurodiversity and individuals who are cognitively and physically vulnerable, then those are in line with what you're looking for. But I'm working on creating within the center a one-stop shop, so we don't have to try to go to the literature in every instance. We've already done the translating for you. So
And then
we're steadily working toward that. If anybody knows any funders who want to fund an interactive web platform for searching in that regard, let me know.
that would be awesome. But thinking back to my experience, I'm sure there's people who have problems that aren't created, that no one knows of, and asking questions just like you said, kind of digs deeper into more problems maybe. But I think being inquisitive and really partnering with the clients and the users and trying to, I think it's gonna develop more, because I'm sure a lot of folks here have design problems that really, maybe it's like a new territory, a new frontier, and how do you go about finding
new territories are very exciting for researchers when we can contribute to the base of knowledge within the industry. That's, as my friend Maggie Calkins would say, that's what makes our socks go up and down. And at that point, if you can connect with somebody who's in either an academic setting or who has a research kind of goal, and they can fill a gap, just be aware that it takes some time to do this. So that's the marathon, that's not the sprint.
Thank you.
Elizabeth, go ahead.
Yeah, just to piggyback off of the resources and the repository, I was curious while you were going over this filtering of resources in the database, is if there's a resource for products, like vetted products, almost like consumer reports, but for either healthcare related or aging related products.
So we don't do any vetting in that regard, because we don't necessarily endorse one product or manufacturer over another. But I think whenever you're looking at the kinds of specifications, whenever I think about, let's say, a floor covering that is going to reduce the number of injurious falls, that you would want to look at the performance criteria for a floor material as opposed to the specific manufacturer of that flooring. Does that make any sense? So like as I'm thinking about incorporating evidence-based design into a specification, I might spec a specific flooring, but I've done so knowing that it has the kind of resiliency that's going to reduce the number of injurious falls. If they're going to substitute out, I've just got the performance criteria that they need to conform to. So vetted products, the challenge with that is they're evolving at such a rapid rate and outside of the scope of knowledge. By endorsing some and not others, we're unfairly advantaging and disadvantaging.
Yeah.
I will say though that the people who choose to both attend as well as contribute to the expos for healthcare and for aging, like they're pretty knowledgeable and pretty reliable in general if you're going to conferencing. And we have a lot of sponsor partners within the center that I have a high degree of confidence in their products as well.
Okay, thanks.
Cool. I'm looking at the time and I want to be mindful of everyone's time. We can have room for one more, maybe comment or questions. Okay. Addie, I want to thank you so much for joining us and giving us a lot to think and a lot of exciting, like I think John said it very well. There's a lot of things that we want to do that we have learned from your session, but we need to figure out how to find a vehicle. That's our job. And how to convince those who sometimes are not, are set in their own ways. But this is where things start getting exciting.
Well, and Philippe, you left a kind of a hanging question out there. Anyone who's interested in evidence-based design, fantastic. If you want to basically put your money where your mouth is and get the credential that can be a differentiating proposition, that's something else to look to the center for. And we have been asked by numerous clients how to write into RFPs that organizations had to have EDAC certification. So just know that that's especially prevalent within the healthcare industry.
Yeah. Excellent. Thank you. In closing, I want to tell everyone here that John and I are planning our next session to be an in-person session at the BSA space in downtown Boston. We are working to have a presentation, but also an experience based around experiencing what dementia or dementia friendly would be. Ruth, I have to connect with you on that. This is really fresh off the press, and I've connected with somebody who has this interactive installation that we would want to use as an excuse also to get together in person, because it's been way too long that we have gotten this committee since COVID in person. So look out for our announcement for September. And any last words, John, Addie?
Thank you. That was wonderful. And we'll see you guys in September.
Yes. Have a good afternoon or evening, everybody, depending where you're joining. Bye.
Thank you so much.
Thanks, Addie, very much. I appreciate it.
You're very welcome.